Welcome everyone to our joint webinar from the Health System Performance Network and IFIC Canada.
A warm welcome to everybody who has joined us for the International Foundation for Integrated Care session in partnership with the Health System Performance Network and many others. We want to say a warm welcome. We have close to 1,000 people registered today already online. We have close to 200. Let's start with saying hello to each other. We know that when it comes to integrated care, the foundation of integrated care is relational. Lessons from all over the world is around the human-centered connection, shifting mindset and behavior for the way we create and redesign our systems of care that were not meant to be connected. We're not designed initially to be connected, and now the global movement is to an integrated care system focused on what's most important to people and their families so that we can reach population health and wellness. Look at all of you saying hello to each other. We have a tremendous audience from Ontario, from across Canada, and from around the globe. That includes the people that have joined to speak with us today, who you will meet, and those of you that have participated in this session. We are close to 260 people who have joined so far, close to 800, between 800 and 1,000 registered. It is such a pleasure to have you. For those of you who don't know me, I am Jodeme Goldhar. I am part of the International Foundation for Integrated Care globally and have co-founded the International Foundation for Integrated Care Canada, the first North American Center for Integrated Care, along with Dr. Wodchis. Our hope and dream is that integrated care often is siloed from each other, but the goal is to create a global movement, a global network for us to rise together, to learn and grow together, to create a learning health system approach in our local communities, across our countries, and across the globe. We can only do that by lifting up, looking out, and sharing what we are doing. Remember that today is going to be highly interactive. It is not a one-way dialogue, but this is a generative dialogue for you to learn, but for also you to contribute your expertise. In order to do that, we will be using polling, and we will highly engaged in the chat function. As you're doing right now, saying hello to everybody, could you please make sure that when you use the chat function, that you make sure you have the button towards all panelists and attendees. I'm going to be able to see all the chats, but your colleagues will not, and either will the panelists, unless you say panelists and all attendees. Take a look. Some of you who are already saying hello are only using to all panelists. So as a reminder, please use to all panelists and attendees. Feel free to use social media to send pictures, to share learnings, to tag each other, to tag panelists, because our goal is whoever is holding space with us today to learn and contribute to how best to evaluate integrated care in your countries and in your local communities, that we're connecting up with people who are not able to be here today. A warm welcome. Over to you, Walter.
Thank you so much, Jodeme. It's such a pleasure to be here. And I'm speaking to you today from the University of Toronto. I just wish to acknowledge this land for thousands of years has been the traditional land of the Huron-Wendat, the Seneca, the Mississaugas of the Credit. Today, this meeting place is still home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. I'd also like to acknowledge that yesterday was National Indigenous Peoples Day in Canada. Across the nation, Indigenous peoples were celebrated. We continue to struggle with the history of our treatment of Indigenous people in Canada, and that is part of what we were acknowledging yesterday, as well as celebrating. From our work in integrated care, we are very focused on ensuring that we can integrate traditional ways of healing with the health system and build trust and develop relationships as we move forward. Today's event brings a whole host of individuals from Canada and from the United Kingdom and from the Netherlands. We're so pleased to have you with us. And today you'll hear from a real wide range of individuals, and these will all get introductions as we come along. I'm going to start the day off by engaging you all in a quick poll, an early one, just to see where people are coming from. So if you would just please click in to the box and let us know where you're coming from today. We have 380 people have signed on so far, and the voting is coming in quite quickly. And not overly surprisingly, most of us are from Ontario today as the hosts for this event, but we have people from across Canada and the United Kingdom and other countries. And please, if you're from the other countries, use the chat box. Tell us where you're from, and then we can welcome you. Thank you very much. Back to you, Jodeme.
Thank you so much, Walter. And I see in the chat from Ireland, Belgium, Sweden. The beauty of virtual, yes, COVID requires that we work virtually, but prior to COVID, IFIC Canada believed that a virtual platform was critical to bring us connected, to break down barriers and allow us to have shared conversations about the areas that are most critical related to integrated care. The evaluation of integrated care has come from those that are part of the IFIC network, because the request to build the skill, competency, and how to do this is critically important. I feel blessed to be joined by Henk Nies. Henk has, many of you likely know Henk for many reasons. I have had the pleasure of knowing Henk personally to understand that not only does he have the skill and expertise, but the value base around how to bring people together in shared purpose to bring about the kind of improvement to health and well-being that is enabled as a result of integrated care. Henk is the Director of Strategy and Development at Vilans in the Netherlands and Professor of Organizational Development and Policy. But he is also an expert in a number of areas: interorganizational collaboration, policy and organizational aspects of care and the elderly, and also, of course, part of the creation of the book around integrating the delivery of integrated care. So Henk, a warm welcome to you, and over to you.
Well, thanks a lot, Jodeme, for this very kind introduction. And it's great to be here. And when I look outside, I think I'm 6 hours ahead of most of you. But when I'm looking in the screen, we're all at the same time and together, although the distance is very long. And that's great of this time that we have this opportunity. Yes, one of the reasons to organize this webinar is that we published a book early this year, as you see on this slide, with on how to deliver integrated care. It's a book which is meant for people managing and organizing integrated care in practice. It has been edited by Axel Kane. He's also the chairman of the European Health Management Association. And we thought it would be good to bring together a number of scholars around the world to publish this book and to write for people working in practice. So it's not an academic book, but it's a book by academics. And if you can go to the next slide, it addresses a number of it addresses a number of topics on integrated care, from funding, financing, leadership, how to engage patients, how to work together, the social dimensions, the values, but also looking at practical issues around digital health and how to implement integrated care, and indeed how to evaluate integrated care. And the last chapter was written by Walter Wodchis and a number of colleagues in Canada in particular. And that was one of the reasons to organize this webinar today and to focus on this. As you could have seen on the previous slide, I forgot to mention that, You can have, if you're interested in the book, it's a pocket book, so it's not very large, it's easy to read, and you can get a discount for the special occasion of today's session. So just if you're interested and you think this webinar tastes like more, please go ahead and use the link. But I'm not here. Oh, here's the advertisement again. I thought it was deleted. But I think it's a great opportunity today to discuss how evaluation can take place in practice in various countries, but in particular, so it should be applicable for your country as well. So I think that would do for the why of this session, of the sort of the case. And if you're interested in more reading on integrated care by the same publisher as the book was being published, the Emerald they also published the Journal of Integrated Care, which is also a very readable journal, very useful for people working in practice, but for scholars as well. I think that would do as the introduction of the book, so to speak, and the reason behind this session.
Henk, thank you so much. And to those that are participating in the chat, thank you for your questions. As will be the case going through this entire session, you're going to want access to links and resources. If we're able to put them in the chat, we definitely will. If not, we will send it in an email to all attendees post-session. There you go. So you will have access to everything that is being discussed today. Also, I would encourage those of you, as it comes up through the discussions, if you have resources and links that you would like to share to our global audience today of close to 500 people, please put them in the chat. We will curate them and also include them as part of the email out to you. Henk, I'd like to ask you a question as a way to start this session. Tell us about how the evaluation of integrated care is being supported in the Netherlands.
Well, integrated care has a history of 15, 20 years, I suppose. And when we look backwards, we see that there have been a number of programs across the country in which integrated care takes place. We have seen a number of pilots within the country, and there has been evaluations on these particular pilots. But we also have seen the past, say, 10 years, larger developments, for instance, for implementing disease management, or implementing, in my field, dementia care, or for instance, maternity care, which are all various different types of integrated care. And there has been also a national approach to that. But we are a country which is very diversified with independent not-for-profit care providers, mostly, with healthcare insurers, with municipalities, so the structure is pretty complex. And we tried to, so in evaluating, we see all these stakeholders have to sort of integrate their efforts and integrate their objectives in order to do a proper evaluation. And we see that the evaluations also may serve different purposes. It can be because of how to measure, is it cost effective, this new type of integrated care, or is it effective in terms of giving the right outcomes and the right outputs, or are we providing high quality care? So the objectives may differ, and we see that the research and the research designs also differ. If I may take an example, we often define at a national level what the quality standards should be on particular services. So there are quality standards on various types of disease management, for instance, and we see that, or on maternity care. And these quality standards are being implemented, and there should be quality indicators, or there should be information indicators connected to all these quality standards. And then they are being monitored on a national and a regional level. For instance, in my field is dementia care. We have published a national dementia care standard, in which you see that in which primary care, social care, long-term care, hospital care all work together in order to provide at the regional level, or at on a network of collaborating organizations. And in this care standard, a number of a number of elements have been defined which should be in place in the various regions. And there were also a number of, it's just 12, but there were also a number of quality indicators being formulated, and they serve the goal of improving the network at regional level. So there are structure, process, and outcome indicators being defined, and they are to be implemented in order, and the regions in our country, the dementia care regions or networks, they can choose on whatever topics they want to implement first, because to implement all elements of integrated care at one time is seen as quite a lot. So they choose the topics on which they want to improve and what they want to implement, and they can choose the indicators that are most suitable. The big issue is, how can you avoid extra administrative burden to those working in practice? So if you have an external evaluation and they are coming just once to see how you're doing, that's one thing. But if you want to continuously monitor the implementation and the improvement of your of the care provision that you deliver, the integrated care, that's something different. So it should be a routine. And in order to make a routine, you should be very much connected to the primary process of those who are working, in this case, dementia care, but that holds in fact for all fields of integrated care. So that's just by and large how we approach it. And I can also say, well, there's a lot of room for improvement when we work with it and bring this into practice, because it's a long way and it's very difficult to collaborate across all these services, all these types of funding which are involved, all these authorities on various levels. So that's pretty much a challenge.
Thanks very
Henk,
much.
thank you so much. Henk has set the stage that this session is looking at approaches to evaluation and what's happening at a local level to create an enabling environment. And you will see from multiple perspectives. Now to Walter to launch our next poll.
Yeah, thank you very much, Jodeme. We were very interested in understanding your purposes, and Henk there just talked about supports for many different people that are involved in integrated care. So we're thinking about your objectives of evaluating integrated care. Is it really local to really understand that improvement for the outcomes for patients? Are you needing to do it for funding agencies and accountability? You can check 1 to 3 priorities here. More than one is possible. So we'll leave the audience almost at 500 now for people participating today. It's really great to see that the most popular item here is learning how to improve outcomes for patients. And I should say patients and caregivers we need to keep in mind. And then early on, we can see from this audience being very interested in about how to set up the integrated care options. And then other things being important, supporting policymakers and understanding design principles also being important. So thank you very much for that, folks. And we'll turn it over to Jodeme to introduce Adam next.
We have the good fortune to have Adam joining us today. And Adam, of course, you can Google about Adam and learn more, but I'd like to share that he is the Director of Data Analytics at the Health Foundation, which is an independent charity committed to bringing out better health and healthcare for people in the UK. He's responsible for developing and leading the foundation's data analytics for better health strategy, which aims to ensure that everyone in the UK benefits from advances in analytics and data-driven technologies such as artificial intelligence. He produces open source tools and approaches that can be used by others and champion better analytics throughout the health and social care system. And he's also part of a team that has designed and delivered large-scale initiatives, such as the Networked Data Lab and the Improvement Analytics Unit at an Informed National Policy. Adam, we're excited to hear from you. Over to you.
Oh, thanks very much. It's great to be here, and welcome to my home in London. You might be able to see that behind me. I'm here, I think, mainly because I have been involved and helped set up something called the Improvement Analytics Unit, which I want to tell you about. If we just advance the slide to the next one, that'd be great. So we set this unit up 5 years ago. It's a partnership with an organisation called NHS England, which really leads the NHS in England and is responsible for providing care for 55 million people. And what we do in the Improvement Analytics Unit is we work together closely with the NHS to evaluate whether local change initiatives are improving care for patients. And many of the national programs that we've been working with over the last 5 years have been about integrated care. So we have evaluated through this unit a number of integrated care projects and initiatives, and I want to share with you some of what we've learned. Our focus really, we're a specialist evaluation team, and what we focus on doing is exploiting the existing data sets within our healthcare system. The NHS, like many healthcare systems, collects an enormous amount of data as part of the routine delivery of care. And what we've been set up to do is to use that data to look at the impacts of integrated care for patients. So we're not offering a comprehensive evaluation service. We don't do work on theories of change, for example, or qualitative work. That work's very important. We work closely with those individuals. But today I'm really just focusing on our core work, which is about the quantitative evaluation. So I wanted to share 2 examples with you, and they're both good news stories. But just towards the end, I'm also going to reflect a little bit about what hasn't worked in our experience when it comes to integrated care. The first example is from Principia. Principia is a coalition of healthcare providers in and around the Nottingham area of England. And Principia did some really interesting work on improving care for people living in care homes, improving healthcare in particular for people living in care homes. And this is incredibly important. What we find in the data is that care home residents go to A&E around once a year on average. They are admitted to hospital almost as many times as that. And of course, emergency admissions are not desirable for anybody if they can be avoided, but they can be particularly harmful to care home residents. The stay in the hospital can lead to adverse health impacts for all kinds of reasons. And around 40% of all emergency admissions for care home residents in England are potentially avoidable because they are for a condition that could have potentially been prevented or treated in an alternative way. So this, it's a great aim, I think, to try to reduce emergency admissions for people in care homes. But what Principia did, you can see this on the next slide, is really implemented an integrated care initiative that had several different pillars to it. That's often a theme of integrated care interventions. They're multimodal interventions, complex interventions. And they align each of their care homes with a primary care practice, general practice. They implemented regular visits from a named GP. So an individual GP was responsible for the care home, went to the care home regularly, in part just to get a better sense of what was happening in the care home and help identify things that could be done better, but also to visit individual residents and check how well they're doing. And they did some medicine reconciliation and a number of other things with the residents. There was a very exciting initiative that aimed to support the nurses who were operating within the subset of care homes with nurses. And this was about providing support from nurses operating in the community. This was very exciting because often the nurses within care homes felt quite isolated before this intervention began. And it was about helping to provide peer support. There was a very exciting program from the third sector that aimed to provide a voice to the residents, and also there was a complete focus on supporting the care home managers. So quite a comprehensive, well designed, also well implemented intervention. And what we wanted to do instead is to look at the impact of this suite of activities on emergency admissions. And the way we did this was to use a data linkage approach that enabled us to identify who within our national hospital data set, we've got a national hospital data set in England, were care home residents receiving these interventions. And then we compared these individuals to care home residents living in similar care homes in other parts of the country. And this is just one chart that just shows you the similarity between the care home residents in Principia, so they were receiving this new intervention, and the care home residents that we were comparing them to. If you're interested, I can drop into the chat some more information about how we selected this control group. On the next slide, you just see the results of our analysis. This is showing the number of emergency admissions per patient, per resident per quarter. The dashed line there is when individuals move to the care home. And what you can see, unsurprisingly, is that in the months and the quarters running up to admission to the care home, there was an increasing pattern of hospital admissions for the Principia patients and also for the mass control set as well. Individuals moving to the Principia care homes have then had a lower rate of emergency admission than the match group, and we took that as an indication that the intervention that they were implementing in Principia was beneficial. There's no sign of this happening historically before the Principia intervention started, but following the introduction of this integrated care program, we can see more positive findings for care home residents. So the second example is from Mid-Nottinghamshire, and Mid-Nottinghamshire have been working on integrated care for a very long time, and I'm not going to try to describe everything they've done. They've done many different initiatives over a period of time. They've had integrated care teams, they've had a single point of access, many different initiatives. And what we wanted to do is look at the combined impact of this suite of initiatives on again on emergency hospital admissions, but we looked at everybody, the benefits for everybody living within the local area. And we did this by comparing rates of emergency admission for Mid-Nottinghamshire with rates for similar parts of England. We used a method called the synthetic control method, which I think is really interesting. And again, I can drop some more information in the chat about that. But I really just wanted to show you the results. I think these are quite important, which is on the next slide. So this is quite a messy slide. What we've got on the first, if you just focus on the left-hand side of the slide, so that's the period up until April 2013. The intervention started in April 2013. You can just see that the A&E attendances for Mid-Nottinghamshire were quite similar to those for our control area. And that was by design. We chose the control area to have had a very similar pattern of A&E visits to Mid-Nottinghamshire. If you then look to see what happened in the subsequent years, you saw that, at least according to this metric, things got worse in Mid-Nottinghamshire in the first year. There were more A&E attendances in Mid-Nottinghamshire than in the control. That's not what we wanted. It took 5 years to see the change that the team was hoping to achieve. And then it was much more pronounced in year 6. This chart's for A&E visits, but we saw very similar patterns as well for the admissions. So what do we take from this? Well, I just wanted to draw out just a small number of reflections. Firstly, we're an advocate for these kind of analytical methods that have a control group. You can find a control group in different ways. The examples that I've just talked through illustrate, I think, that we would have reached the wrong conclusion without a control group. So it's not needed in every situation, but in the situations like the ones that we're looking at, I do think a control group is quite important. And although these methods are quite complex to describe and to implement, resources are available to help healthcare analytics teams, and we're making available a lot of the resources that we've developed through this initiative. You can download the code and resources from our website, so do take a look at that link there. We support healthcare teams in a number of ways to implement these techniques. The routine data, so that's my term for the kind of these data sets that we're looking at, are useful. It's very useful, I think, to look at emergency admissions. They do give a very partial picture about the impact of the interventions. And I would caution anybody to be overly reliant on them. I think they have a role to play within a larger approach to evaluation. And then finally, I just can't stress enough how impacts on hospital admissions can take many years to materialize. I said at the beginning that we looked at a number of integrated care initiatives. They almost all found they almost all aim to reduce emergency emissions for a number of reasons. Very few of them achieve that within the first year. In fact, the Philippa example is the only one. So I think if you're designing and implementing an integrated care program, it's very important to manage expectations about how much you can shift activity in the short term. It would be a shame, I think, to conclude that an initiative has failed after a year when actually it may take as many as 5 years to shift this progress against this metric. And we need more leading indicators of change, things that can shift a bit more quickly so that we're able to point to patient benefit over the kind of timeframes that payers and our beneficiaries are expecting. Thanks very much. Hope that was useful. Over to you, Jodeme.
And thanks very much, Adam. I just want to get a sense of how people here are thinking about using their data. Adam talked about using the data from the National Health System and Health Service. So I'm just going to ask you out here the types of data that you might have locally to do your evaluation work. Many of you are familiar that we are using, similar to Adam, provincial data across Ontario for Ontario health teams, and we've used similar data in the past. But how many are thinking about starting with a registry? How many people are thinking about tracking emergency department use? How many are using primary care data? And my real interest in this is also in knowing how many people have community service data for people who are enrolled in their integrated care programs. Or none of the above, and perhaps you're tracking either none or some other indicators. And if you're tracking other indicators, I'd encourage you to use the chat to let us know what those ones might be. So interestingly, many people are watching exactly that last indicator that Adam had up, emergency, or as it's referred to in the UK, A&E utilization for individuals. Next to that, a very close tie is acute admissions, and then even just having a registry to track who's actually involved in the programs. Some struggle with this, and I think that's really important as well. And then many people do have community service data, so we're very interested in knowing about how you access that and how you're using that. So maybe you could put that in the chat box amongst the other comments that that you can be contributing now. And here, we're interested in having a discussion. You can ask questions of Adam or Henk, or just amongst yourselves as participants, thinking about what are your challenges in implementing evaluation. Jodeme, back to you.
Thank you, Walter, and thank you, Adam. It is important to locate this discussion in the movement around the world, and that there are different vehicles for integration. Sometimes we say, what's in a name? In Ontario, for those that are participating here and for those that are not in Ontario, we have a policy lever referred to as an Ontario Health Team, similar to Vanguard sites and eventually integrated care systems in the National Health Service and around the world, different policy vehicles to support integration. So for some of you who may not be familiar with all the references, that's a little bit of sense making around the landscape and some of our speakers today. In the chat, you'll see many of you are already starting a dialogue, and we think it is incredibly important because you have expertise to bring, but you also are seeking to understand so we can build our shared understanding. Adam, you will see that there are a number of questions pertaining to hospital admissions or A&E admissions and the length of time. Can you talk a little bit about that?
Yeah, absolutely. I mean, it's firstly, there's very lively debate in the chat about the utility of emergency admissions as a metric at all, and
exactly.
I think that is worth reflecting on. The aim goal here is not to reduce hospital activity, but actually to improve care for patients. They're not the same thing. Having said that, I do think that certainly in some situations, there is utility in looking at the emergency admissions, and I gave an example of why they're, I think, particularly relevant for the care home visitors, for example. It's hard to know exactly why it took 5 years in Nottinghamshire to show the improvements. I think one theory is that it just took that long for the interventions to be properly embedded. It's not easy to implement some of these interventions. They're complex interventions. They involve several healthcare teams, social care teams across an area. Not everything works immediately, and there's a degree of time taken to get things properly up and running, and to be improved as well over time. Also it may be that what we're seeing is that the reduction in emergency admissions is actually the result of prevention activity that happened earlier, and it just takes that little long for health to deteriorate to the point at which emergency admissions is required. So the different possibilities. I think what I'd like to emphasize though is that it's certainly not unusual for integrated care initiatives to show no reduction in emergency admissions after a year or two. Very few are subject to very long-term evaluation, like in Nottinghamshire. So we often don't know whether the emergency admissions begin to reduce after 4 or 5 years. But a lot of them do show increases in the short term, and I think that's something to be very cognizant of when designing some of these initiatives.
Thank you, Adam. We can see in the chat you're pointing out the question that Walter posed is, what are the challenges in implementing evaluation? And let us know if these are some common themes that are coming up for you. Policy. Also, how to policies on privacy, sharing information, and how have folks overcome or started to address this. There are also some tools being shared on business and community business intelligence tools that may be able to be leveraged. The main underpinning, and Adam picked up on it very early, is what are we measuring for? How do we define success? And the focus is on health and well-being of people, and how do we measure that across the continuum of care? Richard has shared, sometimes our health interventions have effects outside the healthcare system. We miss this and we don't measure it. For example, an inner city dental program was associated with reduced crime rates by 50%. We need to integrate beyond health, include justice, education, and others. Adam, Henk, would you like to comment? Henk, let's start with you.
Yes, I fully agree, especially with the last comment that to do more sophisticated evaluation, you need to look much broader. But the practical issue is that it is very difficult to combine all data sets from all these various sources. So that's one of the big issues. And also to deal with the privacy issues, how you can connect the data of people from hospital and residential care, for instance. In my country, that's very difficult in terms of privacy reasons, and also because what is a residential home? Even that might be a very difficult issue. But to give a broad picture, it's very helpful to do these types of evaluation.
Thank you, Henk. And Adam, I'm going to refrain from turning to you because of timing, if you don't mind. For our audience, the chat is incredibly rich. We are going to summarize it and be able to share back some information, but please feel free to continue to participate and build on the comments. Walter, to you.
Great, thanks very much, Jodeme, and thanks to the audience for your engagement there and participation, and the value of measuring community data, also mentioned by Richard, and clicking in with measuring days at home. And I wanted to pick up on that because it actually is one of our performance measures in the Ontario Health Team Initiative, that for the older adults, we are measuring the number of days that people are at home. So that's great. That is a good indicator. Now, really, this is going to be a fantastic forum, so stay in your seats. Okay, 2 inspiring examples. Go ahead, Jodeme.
Thank you so much, Walter. And a reminder for everybody participating, please, when you go to the chat, don't just use all panelists, use all panelists and attendees so everyone can see the conversation and participate. So when we set the stage for what are the biggest pain points, which is the conversation we were just having, and how to overcome them or ways to move forward in a local community, we have two incredible examples. One is from Wessex Academic Health Science Network, and the other is from the East Toronto Health Partners and Ontario Health Team in Toronto, Ontario. I'd like to introduce our speakers, Philippa, Andrew, and Dr. David Brown. Philippa is an Associate Director Insight at Wessex Academic Health Science Network. She currently leads a team of evaluators providing independent studies of innovation and healthcare. This work includes looking into the impact and implementation of digital solutions, new models of care, including integrated care and workforce programs. Andrew works as an external strategic advisor to the Wessex Insight team and has helped them design and deliver a wide range of evaluation services for integrated models. He is also a specialist in a healthcare consulting company, Consilium Partners, but before that, he was an NHS Acute Care Trust Chief Executive for 10 years. And Dr. David Brown, in Canada, we refer to as a primary care practitioner or general practitioner, family physician in Farnham since 1997. And through the National Health Service Vanguard program, prior and still in existence to integrated care systems, he helped develop an integrated care team and a new model of care in Farnham that crosses organizational and disciplinary boundaries. This work and its evaluation has shaped the NHS long-term plan for primary and community care. So we are going to hear from the Wessex team first, and then I will introduce our East Toronto Health Partners. Over to you, team.
Thanks very much. So I'm David Brown. Thank you for the introduction. Should we just move the slide on one more, I think? So just to give some context, so I am a general practitioner. I'm not an academic, but I was driven to try and create some change in Farnham to improve patient care, but also to improve the working life of professionals. And at my third attempt at doing this through the NHS Vanguard programme was the opportunity to start developing this change. And we were trying to develop a new model of care for out of hospital care, so care in the community. And as has already been said, this has now become part of the NHS England long-term plan and primary care networks. So for our area, we were an area of 220,000 people, divided into 5 networks of roughly 30 to 50,000 patients. Our area was complex because we were crossing boundaries, local authority boundaries in particular. So integrating care in an environment where there are silos was our aim. The 5 different networks that started developing this, the work started in 2015, we all developed at different rates. So it was a 3-year program, and we could see differences in how people progress depending on the sort of collaboration leaders within each of those groups. Should we move to the next slide? So Happy Healthy at Home was the name given to our Vanguard programme. And there were a number of elements to the programme. So there were a couple relating to mental health, such as the Crisis Cafe and the Recovery College. The ones I was involved with were to do with integrated care. So developing integrated care teams to bring together primary care, so GPs, community health services, mental health services, social care services, and the voluntary sector. We also had a couple of other projects. We had a sort of same-day urgent care project, which brought together different general practice businesses to deliver same-day services to our patients as a sort of collaborative operation. And we had a social prescribing pilot. We weren't doing the extended health in care homes, which Adam talked about from Nottinghamshire, although we did have some of the basics of that programme already. So we were doing multiple projects. There were some others as well looking at routine care, but these were the main ones looking at integrated care. And really our goals were to break down the silos that existed in the health and care system we wanted to have a sort of parity of esteem of all the different players within the system. And most important of all, we wanted patients to only have to tell their story once and not repeat it to a succession of professionals. I should move on to the next one. So our integrated care team, we set up very early, and we had buy-in from our community partners, from social services and community health, so district nursing in the UK. And, you know, we got our team up and running very quickly because of this collaborative approach that we took. We just wanted to get on and do it. And much of it we made up as we went along. We had a kind of attitude of proceed until apprehended, or test and learn, depending on which way you look at it. So we really set up a multidisciplinary team that essentially meets once a week to discuss patients on a caseload. And it's roughly 20 to 30 patients per week. My meeting today was 35 patients. It takes about an hour and a half. And we have all the different players in the room, or at least we did before COVID. Now we have everybody on Microsoft Teams, mostly. But you have everyone who could be involved with the patient's care able to have a discussion simultaneously and produce the best outcomes for the patients. At the end of our intervention, patients are never discharged, they're just dormant, and there are circumstances in which their care would be reactivated for our multidisciplinary team, such as hospital admissions, where we do routine reviews at 6 and 12 months after they've completed their intervention. We initially started off looking at a sort of reactive model, looking at patients who were already on caseloads that we knew about in our various teams. But one of our key things was to develop a proactive approach. So looking for people who we didn't know about, who weren't known to services, but who had needs that were unmet. And for that, we employed a specific role within our organization to do that, and used IT and intelligence systems, which have gradually developed over the last 5 years, to allow us to identify patients and bring them to our multidisciplinary teams. So that's a whistle-stop tour of what we did in Farnham.
Thanks, David. And so Wessex AHSN were appointed to be the independent evaluator for David's system. So for North East Hampshire and Farnham, including David's locality, which is Farnham. And we were busy. We evaluated 23 services, so including here the integrated care teams in 5 localities, including David's localities, social prescribing services, a recovery college for people with mental health, support for people when they're discharged from hospital. And in the right-hand box, it's a summary of the kind of process we followed as independent evaluators. A big emphasis on co-design and spending time up front with the team to understand their aims and get their buy-in. And typically then about 3 months of focused data collection, which is why you need a good relationship with the team, observation and interviews. And at the end, a presentation by that team at a big symposium that we would have organised, which Philippa would say a little more about when I hand to her. Next slide, please, Walter. And so this is the logic model that we developed with David back in probably 2015 for his integrated care team. You can't read the logic model, but what we pulled out here are some of the highlights. And what we found with all the logic models for integrated care, sure, people wanted to reduce people coming to hospital and have an impact on activity. But what to us came through louder was wanting to have an impact on relationships and how people feel. People in integrated care teams describing wanting to give their patients a greater experience and confidence to manage their own healthcare. They want to be in effective teams and improve relationships across agencies. Next slide, Walter. So as we developed our evaluation offering, we went out to look for evaluation methods that could answer the questions or measure the impacts in those logic models we were developing with frontline teams. And we put a lot of effort. You can see here we had a partner and activity impact, and all the effort that goes into getting pseudonymized data sets to track activity. But the two I'm going to pick out today for you are the work we did around self-reported outcomes for our outcomes, and the work that we did with the Centre for Implementation Science at the University of Southampton around understanding teams as hopefully a different way of thinking about how to evaluate integrated care with an emphasis on feelings and relationships. Next slide, please, Walter. So self-reported outcomes, from our outcomes, it's a provider that we've used a lot. They've got this wide range of simple surveys so that patients, staff and carers can self-report against a range of ambitions and feelings. So we collected these. This summary slide is for the 3,300 responses we got across North East Hampshire and Farnham. And this highly summarised bar chart on the left describes the before and after against 4 of the measures we use. The longer the bar, the more positive people felt. And before would be at referral to the service, after would be once they've been supported. And you can see for all of them, we found a significant improvement in how patients responded to how they feel about their health status, their confidence to manage themselves, their own personal well-being, and their experience of care as they experienced integrated care. Now, clearly, we were able to break this down by sometimes by patients and certainly by team. But overall, in North East Hampshire and Farnham, patients described the biggest improvements in services being organised, being able to get the right help when they need it, people listening and explaining things to them, and being able to be seen promptly. And as someone that spent their life in the NHS, that can only make me smile to hear people feel and describe that experience. And Tim Benson from Our Outcomes, who invented these measures, is on chat if people are interested today. Next slide, Walter. And this is a busy slide, so apologies for that, but there wasn't a way of simplifying this one. This is the work we did with the Centre for Implementation Science at the University of Southampton, one of our local universities, around team development. So David's team, David's integrated care team, that photograph of people sat around the table described what they wanted to get from working together as a team across multi-agencies. And normalisation process theory is a validated instrument for understanding in practice how teams come together, implement a change, and embed it. It's got there are 4 domains to it around the outside, around coherence, how meaningful staff think the tasks are, cognitive engagement, how they actually participate in practice, collective action, how well work is structured and delivered, and reflexive monitoring, how they feedback and understand what they are doing. Now, we collect and measure data using normalisation process theory through our qualitative observers going in and observing and sitting and watching the integrated care teams in action. And you can see on here the differences we could see between the 5 integrated care teams in North East Hampshire and Farnham. This was really helpful to the teams as they were developing. So I'll quickly hand to Philippa.
Thank you. So there were a number of actions that we took as a team to facilitate the success of the evaluation. And the first of those was to co-design the approach. So we sat with the stakeholders, with participants, to design the specification for the work and to agree that up front. Andrew mentioned before the symposia, these were 3 large events that we held with a range of participants, system leaders, policy advisors, other systems, where the teams themselves shared the findings from the evaluations. We also contributed to conversations about how integrated care could be further developed by attending community of practice events and by taking our evaluation tools to team away days, like the MPT just mentioned, so that we could baseline and review how teams were developing. We included evaluation findings in monthly reports to commissioners and introduced into those dashboards the self-reported outcome measures from patients and from staff. And we also made our outputs highly visual and accessible to a wide audience. We created flashcards. An example will come up shortly on the right of your screen from Farnham ICT. Walter, if you can press, please. And a lot of our outputs took a form like this, summarising some key findings. And we also made sure that our reports were timely, so that they were produced in a way that could inform commissioning decisions particularly about what to continue to commission or to decommission, or to inform adaptations to services as they evolved. And the final slide, Walter, please. So we have some tips from our experience. I'll just talk to a few of those, mindful of time. The first is around relationships. It was really important to build a partnership between evaluators, participants, and stakeholders to ensure that we had that commitment and everybody understood the value of evaluation for them. We also produced regular interim reports, had frequent check-ins with the teams so that they could use the findings formatively. We identified some champions along the way who were extremely helpful in unblocking and innovating if we had any difficulties with data collection on our journey. And we used a number of techniques to understand how people feel about integrated care, how that was really received. And finally, we undertook and would recommend a comprehensive evaluability assessment at the start of the evaluation, but also repeated throughout. And that helped us to identify what was truly realistic within the time frame. And we've spoken about that earlier in the webinar. And also the potential limitations and constraints of the data that was available and what new data would need to be collected. Thank you.
Thank you so much to the team. And it's a very active chat, and we're going to open it up for discussions after we hear from our East Toronto Health Partners Ontario Health Team. I'd like to introduce the team that's coming to you today. Mark Pham, Sara Shearkhani, and Anne Wojtak. Mark works at Michael Gehring Hospital and is the Vice President of Clinical Programs and is a partner as part of the East Toronto Health Partners Ontario Health Team. Sara is the evaluation lead and Anne Wojtak is the integration lead. Together, along with multiple partners, bringing out a very high-performing Integration Ontario Health team in Ontario. I'd like to turn it to the team to share their local work.
Thanks, Jodeme, and thanks everyone for the amazing participation so far. I'll get us started and then hand over to Sara and then Anne. So first, a bit about East Toronto. We are, as it sounds like, in the heart of the east of the east side of the city of about 4 million people. East Toronto serves around 300,000 people with probably another 100,000 who come into the community. And as you'll see, we have a diverse set of community stakeholders, a number of different sub-communities within East Toronto, from hosting Toronto's Little India to a large South Asian population to Little Chinatown to the beaches and a whole range of different communities that make up East Toronto. So when we looked at the opportunity to come in Ontario Health Team, really Ontario's response to integrated care, we were excited. We thought this is an opportunity to really think about how we serve the needs of our communities in different ways, and brought together effectively 6 anchor partner organizations and over 50 different partners to deliver service in East Toronto. When we thought about the OHT and some of what I've heard so far in the discussion, we were really conscious to bring, yes, the obvious of hospital and community, but really specifically to bring anchor partners that would represent and pull in different facets of what health and social care looks like, from hospital to community support services that include employment, food security, income security, rehab, long-term care, primary care, home care, and many others. And what's unique in East Toronto is we did start what we call the East Toronto Family Practice Network, which is a formal coalition of the 260 family physicians who serve East Toronto to form a board and really start to organize primary care in a way that, at least in Ontario, we don't have today. So as you see on the slide here, we serve 21 different communities, which really are a unique blend in Toronto, ranging the full spectrum of the social determinants of health, from some of the richest neighborhoods in Toronto to some of the poorest, and from some of the highest settlement to the highest new immigrant. And so it really is a range of the kinds of communities and services that our community needs. And what's interesting about East Toronto as well is that we are very much embedded within a broader Toronto ecosystem of a number of large academic centers, a number of different communities all around us in serving a very broad population. When we started, if we go to the next slide, Walter, when we started the work as an OHT, we chose to focus on really kind of 3 key areas of population health focus. So firstly, seniors and chronic disease. We do have a large seniors population, and chronic disease management, I think, for all integrated health systems is a core focus. But we also chose two specific areas within mental health and substance use. The first on adult substance use and health, where we saw a significant need and rising need around not only the opioid crisis, but broader substance use needs. And we've seen initiatives start already in areas like building integrated substance use and primary care hubs. But the second area was around youth mental health and wellness. And again, we have a number of pockets within East Toronto with large youth mental health needs. And we have looked to build not only kind of broad youth mental health hub spaces, but also akin to what we just heard in Farnham around complex case management services for youth to make sure we really are bringing teams around the table to think about how we serve youth in a different way. And then underpinning those three population streams are some kind of core elements, how home care is changing, how we think about really locally driven care and integrated social services, and building out primary care-based hubs that really serve kind of 4 sub-regions within East Toronto. The one glue, if you will, that we've used to start to foster this is what we've called integrated surge. And this was a conscious effort by the hospital to shift about $1.5 million into the OHT to support what we call community surge, but really is about doing tests of change together as an OHT to invest in helping supporting the community surge up during the classic winter season at the same time as the hospital, and have now shifted that to be more just part of the broader OHT asset. And I think we're seeing that shift to assets and thinking about how we all collectively invest in each other as OHTs across Ontario. And so this was kind of our first toe in the water. And as part of that, we were really conscious to invest in evaluation right from the beginning, not only in evaluating surge itself and how we think about the co-design around surge and learn through that, but also to really invest in valuation overall as an OHT and make sure that we're starting our journey as a learning OHT right from the beginning. And so with that, I'm going to turn over to Sara Shearkhani, who will talk a bit about our evaluation work.
Thank you. Next slide, please. So the aim of our evaluation is to create a learning health system within our OHT by embedding rapid cycles of evaluation. And to do so, we have partnered with scientists at University of Toronto and more recently with HSPN. A postdoctoral position, my role was created to support creation of an OHT evaluation framework and a community of practice, and to support decision-making and KT. Our approach is a developmental approach, so the main focus is to support learning at the OHT level and at the project level. To start, 15 surge projects were chosen to be part of this evaluation. Next slide. Then an evaluation steering committee was created, including patient partners, to oversee the evaluation work. And doing so, we ensured that the evaluation process is continuously assessed and refined as needed. To build internal evaluation capacity, we created a series of workshops based on this evaluation framework developed by Walter and his colleagues. So the first workshop really focused on making sure that all parties involved spoke the same language and pursued same goals. The second workshop focused on developing logic models, and the third on choosing measures. So all teams, each team had to create an evaluation plan using our evaluation plan template that consists of 3 main elements representing different components of this framework: a logic model, evaluation questions, and measures. And I will walk you through our evaluation plan using a search project as an example. Next slide. So the first component is a logic model, and we used HSPN resources and chose this template for our purpose. And the example that I have here for you is a surge project that received funding to support early discharge for patients with non-medical needs. So for example, a patient ready to be discharged but could not leave the hospital because they had some hoarding issues and faced eviction. So the team worked with the family and the patient to identify this issue, approved fund for a deep clean, and they were able to discharge the patient. The goal of the logic model was for this team to map out all the steps required to get them to their desired state of care. Starting with identifying the overarching goal, the impact, which was alleviating winter surge pressure through reducing length of stay and improving discharge process. So these are the outcomes identified by the team. And from there, it was all about identifying resources, and activities required to achieve these identified outcomes. Next slide. So the next element is evaluation questions. So team had to think about the purpose of the evaluation. What did they want to get out of the evaluation? In our search project example, one of the questions that the team focused on was, what are the common barriers to discharge? So one key goals of the evaluation for this team was to help with future planning. So say by the end of the search period, if it turned out that one of the common equipment purchased was walkers, then the team could purchase and store walkers ahead of the surge next year, and doing so shorten the approval process and thereby reducing length of stay. Additionally, the idea was to limit, like thinking about the evaluation question, the idea was to limit the scope of the evaluation. So the message was that the logic model can be ambitious, but you might not be able to evaluate all aspects of your program because of a host of reasons, for example, capacity or level of maturity. So teams really had to think about the purpose of evaluation to limit the scope of their evaluation. Next slide, please. And the next step was for each team to choose appropriate measures aligned with their evaluation questions, and in alignment with one of their evaluation questions for this team. What are the common barriers to discharge? The team focused on identifying the common barriers to discharge from staff perspective and type of services equipment purchased. And then they had to fill out this template, again, created by Walter and his team, identifying sources of data, approaches to data capture, frequency of reporting an audience, and then identify person or persons carrying out this work. And this turned out to be a great exercise for the teams because it helped them to further limit the scope of the evaluation. They had to think about the capacity, the infrastructure to operationalize their evaluation plan. Next slide, please. So once the evaluation plan was finalized, teams started data collection and analysis, qualitative, quantitative, which at times meant that they had to go back to the evaluation plan and adjust it. We supported the teams during this stage with more workshops and team supports, one-on-one meetings. And then at the end of the search period, evaluation reports were co-created by the team summarizing the learning. We have shared the results with our evaluation steering committee, gathered their feedback. Today, in fact, actually, we are going to have a webinar sharing the results with all teams and celebrating their work. And now to Anne to talk about next steps.
Next slide. Thanks. I'm just going to wrap up with a summary of where we go from here. As you can see, the evaluation work that we started was about 3 years ago, before we were actually a designated Ontario Health Team. And so as we've shifted over the last few years to more integrated care across East Toronto, we're spreading and scaling this evaluation work. And our goal is to develop as a learning health system. And to do that, we're using the framework that was developed by Reed and Green, which is on the left, Green and Reed, sorry, on the left-hand side of the slide. And the idea is that you go around the 6 phases, and you can see actually the evaluate phase, we've embedded Sara's evaluation framework that she just referenced. On the right side is a description of our kind of maturity path. And each time we go around the learning health system cycle, you know, we learn more, we grow more, we get more engaged, and we get better. And so, you know, when we started 1 to 2 years ago, or in years 1 and 2, we started with a third-party evaluation and some initial tests of change. Now we've got the embedded research position, we've established our steering committee, we're doing some capacity building with our teams. And so I think the stage we're at is really helpful for those OHTs that are actually thinking of doing the impact fellowship. We've got some good learnings there. So that's something that, you know, we'd be happy to share. But we'll continue on these cycles till we get to this stage of fully embedded rapid learning cycles and capacity across all our teams. And that will be in a couple of years, I'm sure. Back to Walter and Jodeme.
Thank you so much. to all of our guests for sharing what it looks like at the local levels. We have one quick poll just before going in to get a sense of the grounding of where you are and how you are evaluating your integrated care initiatives. So if you could just pop in and say whether you have internal robust evaluation, whether you're working with external supports, whether or not you have measures that are tracking with your steering committee. There's a glitch in the middle of that within 1 to 3 months, and whether you have no explicit plan. So 1, 2, 4, or 5 on those options. Okay, I'm going to cut this one off a little bit earlier just to get a sense of where people are at and share these results back out. And it looks like our dominant one here is having measures that you're tracking with steering committees and working teams, your own set, but a good number having internal robust evaluation as well. And then finally, about a quarter of our respondents still not having an explicit plan for evaluation alongside your care activities. So hopefully this will be, today's webinar will help you think about how you can go about doing that and look at some of the tools that would be available to you. And yeah, I really like in the chat, some people really pointing out, we need to be asking what matters most to patients, staff, and that would be, I think, my leaping off point for this part of the discussion.
Yes, thank you so much, Walter, and to everyone who's participating in the chat. There are themes emerging for our conversation. One is around co-design, and sometimes we talk about this work is a shift in mindset and behavior in building the most emergent skills and capabilities to work across multiple perspectives and lenses. So together, we have collective impact, stronger than any individual or organization can have, but across a full continuum of health and social care. One of the pieces that emerges and is critically important for IFIC Canada is the partnership with patients and caregivers, citizens, clients, and caregivers in the co-design process. In building off some of the most recent literature around new power approaches to change, where power for decision-making is shared across those that work in health and social care, those that are in evaluation and policy roles, and those that receive care and support people who receive care. To our 2 examples and panelists, can you talk about the co-design process and the partnership with patients and caregivers? David, let's start with you. I know you started with a response in the chat.
Sorry, about the caregivers, did you say?
Patients and caregivers,
Yeah.
carers. Okay.
Yeah, the ICT, so our integrated care team meeting, which is once a week, is purely a professionals meeting as a sort of overview of care, coordinating care, deploying staff. What we did was within our team is sort of come up with a sort of trusted assessment that any of us would use. So any member of the team going in to see the patient anew would take some background data that would be useful to other members of the team. So although, for example, a financial assessment is not of much interest to me as a GP, it is of interest to our social services team when they're assessing whether the patient is entitled to state-funded care. So we would collect enough background information on that first contact with the patient to allow other people to make judgments. But also the interaction with caregivers, families, and the patients themselves was based on the professionals involved with their care directly. So we never felt there was a need for patients to be involved with a multidisciplinary team meeting because most of those care decisions are made with the patient themselves by the professionals. So this is more about coordination.
Thank you, David. Philippa and Andrew, anything to build on that before I turn over to our East Toronto Health Partners?
I think just to say on the co-design, I think what we learned really quickly is at the beginning of the evaluation is to sit down with the team, the new team that are delivering the new integrated care model, and start and get them engaged in designing the logic model and being on board with what are the evaluation questions. They, in the main, they love that. It's not often someone sits down and asks them, what is it that you want to deliver? What is it that we can help you understand about the service that you're delivering? And then that you get the right evaluation questions when you co-design it with them, and you get their buy-in to data collection, because they have to go the extra mile in order to support the data you need to evaluate. So a different kind of co-design, but we learned early on that getting them on board at the beginning was vital.
Thank you so much, Andrew. And as we talked about in the chat, the focus is on health and well-being for people and their families, defined by them. And so how does that sit as a grounding feature of the work we do and how we evaluate? And around the world, we're developing this capability and learning from each other and building from strength to strength. Anne, would you like to respond for East Toronto Health Partners and your approach?
Sure. I mean, Sara mentioned our evaluation steering committee, which we just set up in the fall, and it was important to us to ensure that we have at least 2 caregivers and community partners who are involved. But I was also going to suggest Mark talk about the initial surge workshops we did, which were all co-designed, even from the first ones from a couple of years ago.
Thank you, Mark.
And yeah, certainly for our surge workshops, we really did take a co-design approach with all of our East Toronto Health Partners in the terms of the providers and the professionals, but also together with youth, with folks with lived experience in substance use, with folks who experience ongoing chronic disease, folks from our seniors population. So as we thought about our populations, we engaged those in that design of the vision of the whole work, but also in the actual initiatives. We also have carried that forward. So this has been a kind of 3-year journey into this co-design effort. Even down to, as in our youth mental health streams, developing, working with youth to define what wellness looks like to them, what a wellness framework and how they would start to prioritize across that, how that translates into digital environments that we help youth, their caregivers and providers all create and co-create together. So we really have tried to bring this, you know, from the early stages all the way through all of our work. I think it's critical to how we design right.
Thank you. Oh, sorry, Sara, go ahead.
3 of the projects that we evaluated were actually engagement, focusing on engagement, youth mental health engagement, caregiver engagement, and community engagement. So we had those 3 projects as well, specifically focusing on engagement. And I would say that we are taking this work further, trying to evaluate our engagement process as well.
Thank you so much to all the teams. And you can see in the chat that this is such an important area of focus, and we have a lot of opportunity to discuss co-design across all partners that work in health and social care, and co-design opportunities in equal partnership with people and their families. Thank you for those of you that are so engaged in the chat. And there's been many other questions that we hopefully our 2 teams can respond to in the chat. One in particular around how do you ensure that this is not a burden to the teams that are doing the integration work, and how do you bring this into the DNA of the change process so people feel well supported? So for our panelists, if you could put your answers in the chat, that would be wonderful, and I'd like to turn it to Walter.
Great, thanks very much, Jodeme. Really great to be back. I just learned a tremendous amount on implementation, on the things that are important. And you know, these are programs that are doing things with resources and thinking about doing them at scale. You may not have, and I can tell from the chat, everybody not necessarily having all of the resources, but these are really good indicators of the things you can do, and then choose those things that are most important to you and think about what you can be doing as opposed to saying it's too much, I'm not going to do anything at all. And I think, you know, I'm just going to highlight some of the pieces that came out from writing this chapter. One is to think about that, you know, what was your purpose? Are you trying to measure the endpoint game of effectiveness, or are you just trying to improve the design supporting development? And then think about what methods you really need for those pieces of questions. Things you need to be thinking about, you know, who are your priority populations? Do you have a conceptual model for how this is going to work, or the ways that you expect things to change? The logic models don't tell you about implementation, but they sure are very helpful in making sure that you've thought about what you're trying to achieve, what activities that the individuals involved in the programs are going to actually have to do in order to get those outcomes, and what resources are going to have to be put in place. Do we need new roles? Do we need to shift work? It can't all be an add-on. And that's what I think really comes from filling out the logic model and then thinking about the measurement and data capture. What are the most critical elements? And often we're doing evaluation and people will list out 20 or 30 things that they need to be doing. And what are the 5 or 6 that you need to be certain that you're doing, and track those and find simple data capture methods for that. And then that feedback, if you're doing the data capture and not providing the feedback, then frankly, I've made that error before myself. And I say I wasted my time in capturing a lot of data that we didn't actually make sure was used to adjust the program. And I'm not going to go through this. You saw how it was used in East Toronto, and that broad approach and that value of using the logic models and having people work through. You saw in North Farnham with one as well, and you'll see these quite clear. So I'm just going to say that we have done a couple of webinars specifically on using logic models and using measurement from February and November of last year. I'd suggest you go back and look at those. And we've also developed a bit of a template that you can use handy around logic models and measurement models. And those are the ones that Sara referred to. So again, these are just tools in a toolkit to help you do your best. I'm just going to leave off with a couple of reflections. We heard in the beginning from Adam around sort of external evaluators. And I was thinking this a little bit more. All external evaluators aren't doing it this way, but that, higher level national or provincial data. And I think what you saw there was seeing some unbiased evidence regarding the development and implementation success. And these programs can often have access and use external data sets. So you yourselves may not have other people's data. You have your own data. But Adam talked about that comparator or counterfactual information. And for those who saw our work on health links, you saw a pretty poignant example of regression to the mean, where if you were looking at only the health links cases of previous integrated care initiative in Ontario, you would have seen that after the implementation that healthcare utilization went down. Indeed it did. But when we pulled in our comparators that were also rising in risk and use, we found that their healthcare also went down. And in fact, we found it went down by more. That was a short run, just a 1 year. So it'd be interesting to see what happens 4 or 5 years out if we stick to the programs. And I still think that even with these external pieces, and Wessex talked about co-designing the evaluation goals and objectives, you can still be doing that even with the external evaluators. But what about the local evaluation? I think this is really helpful to think about doing things yourselves. And quickly building trust, because you know the people already, and leveraging those existing relationships. There are opportunities to bring in some extra resources. In Ontario, we have an Ontario fellowship program right now, the Ontario Health Team Fellows, that are really about helping OHTs have extra resources and individuals, people like Sara, to help implement evaluation plans. Look for things like that, those opportunities. At the local area, you can also think about coaches to the frontline providers who will need coaching on evaluation approaches, setting the questions, developing logic models. That's not something that people are trained to do ordinarily, but can be embedded and made to be highly useful as people really think through how they're doing and why they're doing things the way they are. One of the things I'll say is many people talked about data access. It's going to be easier at the local level necessarily than handing it over to external parties in general. To do this well, it needs to be an organizational priority. You can see in these programs, it was an organizational priority. And therefore, it's something that they're building over time. Your first piece of evaluation will not be your last. It will be your first. Again, some of these pieces are highlighted in that book, and there is a discount if you decide to purchase that today or following today's event. Today, I'm pleased as the co-lead for IFIC Canada that we were able to bring so many different components and pieces together. It's a lot to listen to. You can go back and listen to it. It'll be available on the HSPN website in the week or so, as well as the slides. Thank you very much from here in Toronto at the University of Toronto.
Walter, thank you. I really appreciate Walter's final piece around organizational support. And when he says organizational, he no longer means the traditional word of organization, which is a separate entity, but organization as a health system. We now are taking on integrated care systems or integrated care work, no matter where we are in the world, and shifting our mindset from organization to shared purpose across a health system to reach the goals of people and their families. And in order to do that, we are helping convene learning across the globe and building bench strength across North America to also share what's happening across Canada and the United States and have a global conversation to enrich our own knowledge and experience globally. The next International Foundation for Integrated Care conference is being hosted by IFIC Canada, the first North American center on integrated care. It will take place the first week of October, and the focus is on co-designing for health and well-being with individuals and communities. The entire session has received patients included designation because patients, clients, caregivers are equal partners in designing and going to be equal partners in delivering and in attending the conference. We have a couple areas of focus that I think would be of interest. This tension, the polarities we hold between top-down and bottom-up work, whether it is how does policy work with local leadership? How does evaluation at a national scale work with local evaluation? And a number of areas so that together we create this movement to improve health and well-being in our local communities and across the world. We have a favor to ask of you. In the chat, as you're leaving, do one word that describes your experience with us today. Panelists, please participate. And for the 300 of you that are left online from across Canada and around the world, say goodbye with one word that helps describe your experience with us today. To our panelists, a warm thank you. Your contribution was incredible. For those of you that have participated and used the chats and the polls, can't tell you how valuable it was to learn from your experience, your comments, and also all the information you gave. A warm rest of the day. It's evening for some, afternoon for others. We will continue to be here to bring us all together in shared purpose to learn from each other. I hope our panelists see how this one word sometimes can be incredibly uplifting and a quick piece to show how relevant our conversation was today, and obviously very much so. Wishing everyone a great rest of the day. Look forward to seeing you at our IFIC Canada conference being held the first week of October. Abstracts are still open to submission until Friday. Happy rest of the day, everybody.